about the intravenous, and I'll give you a little bit of history in that, because this intravenous, using intravenous versus IV anesthetic. So let's go a little bit over this. So hypoxic pulmonary vasoconstriction. Now think about it. What is hypoxic pulmonary vasoconstriction? Is basically what it does. It's a protective mechanism, right? It takes away blood from hypoxemic area, right, and divert it to an area that is not hypoxemic, have good blood flow, good oxygenation. So it's divert blood flow from hypoxemic area to well oxygenated area. It's a protective mechanism. But and in fact, this Brian Marshall, and you said that in the last 20 years, you don't say, Brian Marshall devoted his life from Penn University, and he showed that during hypoxemic, if you make part of the lung hypoxemic, you expect to have a PO2 right here about 100, instead of like 400, because of hypoxemic of HPV. And as you know, HPV slash 50% of the blood flow that goes down. So if you have one lung ventilation and 50% of this shunt goes down because of HPV, you end up with about 27% shunt totally. It's important to remember 27%, because once you go above 30%, increment in FiO2 will not respond anymore to increment in oxygen partial pressure. So you want to keep it down. So there was a whole discussion in inhaled anesthetic, do influence HPV or not? That was going between Brian Marshall and Benamov years ago when I was still a fellow. They come on the stage and fight with each other for hours about it or not. One of the studies that look into this to define it or not, there was this study they do microspheres, radiological microspheres, so you can see the flow. And this is during two-lung ventilation. This is the flow during two-lung ventilation. This is the upper lung, this is the lower lung. They can look exactly the slice, basically the lung to different slices, we can see the flow. And if you go to one lung ventilation, because of HPV, the flow goes down in the upper lung, and it's increased in the lower lung. Now, if you add isoflurane to it, look, so it shifts back the higher flow in the non-dependent lung and decrease the flow in the dependent lung. So that was kind of answer to say that HPV, which has a lot of different component to it, but inhaled anesthetic usually will blame to be part of the hypoxemia that we attribute to the hypoxemia because of HPV. And Karen Domino looked at this and analyzed it in the lab, and she found that 1 Mac of isoflurane will increase the shunt in 4% for 20 to 24%. So 1 Mac of isoflurane increased the shunt to 4%. Now, think about it. It's a very interesting mechanism, because what is happening in the other part of the body? This is a microcirculation, and try to bear with me on that. Here you can see the red cells going, I'll show it to you in a minute, and here they're looking at 3 parameters here, and if you look at the red cell here flowing, there are 3 parameters, right? The FiO2, and you can see here the saturation. Now, and this is the oxygen delivery. Now you look at the red cell. So here's 3 things. We can see the oxygen delivery, the FiO2, and the saturation. So look at this here. Look at the red cell on this tissue for a minute, okay? Now I'm going to bring down the FiO2. I'm going to create hypoxemia to these things, to the tissue here. Now look what happened when I create hypoxemia. You see the whole tissue is flooded with red cell. See that flow that come up? Now, if I go to maintain oxygen delivery, now if I take this hypoxemic mixture and I bring it up again with oxygen, I'm going to increase the oxygen again. Look at the red cell. What happened to the red cell? In a minute, I'm going to increase this up. It's coming up. And a minute later, all the red cells that flooded this tissue disappear. They're gone. So what that mean? That means that this is very interesting, that the lung behave totally different than every part of the body. Every part of the body, when you have hypoxemia, the red cell goes there to maintain the oxygenation. The lung is the opposite. It's a totally different mechanism. And at the end of the lecture, I want to tell me, you need to tell me why, and I'll send your response to Stockholm to get the Nobel Prize for it. So we talked about all this subject here before, lung isolation. I talked about the first lecture. I told you that I'm going to leave it to the end because of what I showed you, the effect of inhaled anesthetic on one lung ventilation, that TIVA is the best, because you have to use TIVA because inhaled anesthetic influence the shunt, will increase the shunt. And we used to do that. So now we thought TIVA is better, inhaled anesthetic is out. It's not the way to go. And that was and we talk TIVA, we talk about propofol. And if you go in the United States and you say, what you're going to give me to sleep, I said, propofol. First thing they ask, they said, is it Michael Jackson drug? And then they have here, you can see the trial that was in the Michael Jackson trial, and talk about propofol became very famous. Everybody was afraid to get propofol. It's good for us to tell them, you didn't have me with him. If you had me with Michael Jackson, it would not happen. And that's very good for us as anesthesiologists. So keep calm, give more propofol. So everything is propofol, propofol, propofol. Now, and studies, however, that look at propofol versus sevoflurane here in this patient didn't find much difference in oxygenation, really. And this is another study, look at sevoflurane and propofol during one-lung ventilation at different time of the one-lung ventilation. Didn't find really anything significant to say. Now, all of a sudden, the last 5 or 6 or whatever years, we start to say, wait a minute, propofol is not so good. Be cautious with this. Why? Because the Cohen from Switzerland allows that actually, this is bronchoalveolar lavage, much higher inflammatory factors with propofol. And if you look at all the inflammatory, tumor necrotic factor, IL-12, IL-6, much higher with propofol versus inhaled anesthetic. And the postoperative complication. This is with propofol, 40 patients versus 18. So actually, propofol now is out. It's not good to use propofol. Why? And then the whole thing come out, why inhaled anesthetic actually protect you against hypoxemia. So there are two concepts that I would like you to know. One is tight junction, and the other one is Glycocalyx. Now bear with me with this, because otherwise you lose me if you don't follow me here. Okay, so first of all, the tight junction. There is a tight junction, is a protein that maintains the two cells right here. You can see that. They maintain the cell together. You can see the microscope, electron microscope right here. This protein maintains, if you lose this protein, you have a leak. And you have a leak of the substance, inflammatory factor into the intralumen of the pulmonary, of the alveoli. And this is actually done by what you call occludin zone 1. Occludin zone 1 is the protein that tight connects these two cells together. It's appeared to be that isoflurane or sevoflurane maintain this protein to keep the cells tight. Okay, and if you look to this, for example, how do we prove it? So if we take, for example, cells and we try to create infection in these cells with lipopolysaccharide, and then we try to create damage from high ventilation, tidal volume, stretch. We stretch the cells, so we can lose the tight junction, lose the amount of this protein, the occludin zone 1 that I told you. It's a very important protein. But it's appeared to be, if you use isoflurane with this model, you don't use the tight junction. And I'll show it to you here that they did it in mice, and you can see they did the whole thing. So here it is, take a look here. This is the occludin zone 1 that I talked about. This is the amount of occludin zone 1, the amount of this protein that keep the cells together. So if you look here, this is control. We don't create any damage. With no isoflurane, with isoflurane, does make a difference. But if I create now in these cells, I'll create damage by infection, lipopolysaccharide, and stretch that I show you. Look at the amount of this occludin zone 1. Went down, not like before. So, but if I put to this back isoflurane, it's restore again. And if you look here again, with no normal, with isoflurane, look, the amount of this is a protein in the alveoli, much higher without isoflurane than with isoflurane. So isoflurane keep the tight junction. The second concept of isoflurane is Glycocalyx. Who knows about Glycocalyx? Anybody heard about Glycocalyx before? A couple of you. Okay, Glycocalyx is a dense coat that is on the cell that protects the cell right here from maintain the barrier of the cell. And if this Glycocalyx in inflammation, you lose it, you lose this tight junction here, and you have leakage, and you have inflammatory effect, increased permeability of the cell because losing of this Glycocalyx. And you can see it here. Look, this is a normal Glycocalyx of the cell. There's an electronic microscope. And then with damage, if you create perfusion, hypoxemia and perfusion, okay, damage, you lose the Glycocalyx are gone. If I use isoflurane, they're back again to the, and you can see with adhering of the platelet, because if you don't have Glycocalyx, the platelets would adhere to the cell. Here you can see here, if I create, this is baseline, I create damage to the cell with perfusion, hypoxemia and reperfusion, warm hypoxemia, warm perfusion, and you can see how the platelet adhesion increase, but I give isoflurane, it's gone down. So isoflurane protected by that. However, clinical study, in the study for Switzerland, they look at a prospective study of isoflurane versus inhaled anesthetic in about 250 patients in each arm, find out that it did make no difference whatsoever in terms of 30-day intra-hospital complication and 60-day after. If you look, it's exactly the same. This is intra-hospital. 6 months later, the complication between isoflurane and inhaled anesthetic were the same. They were not different with the inflammatory factor. So we might say that we thought until now that inhaled anesthetic are good, isoflurane and propofol are bad. Now, if we think about it, we continue to say use propofol. Wait a minute. There are evidence today that if we use cancer surgery and you give blood to the patient, the incidence of post-operative metastasis increase in the patient. And you can see it here. This is the metastasis with, and this is with blood. This is saline. Same thing intraoperatively with blood and with saline. You give blood to the patient. This is platelet. There is increment of this with platelet as well if you give platelet. And this month's analgesia and anesthesia, this May issue, there is an editorial and an article looking, can perioperative anesthesia care patient, cancer, lung cancer, can we change outcome with that? And it's, if you look at this here, it shows you that if you use any of this anesthetic, if you go with intravenous anesthetic or you go with inhaled anesthetic, there is no comparison. The intravenous anesthetic are much better than intravenous anesthetic. There's less incidence of post-operative metastasis in surgery for different reasons. Morphine have been known to create higher metastasis with different mechanism. But if you look at propofol, okay, propofol promote the natural killer cell and toxicity, and propofol reduce the cell mortality effectiveness of the cell and inhibit glycogenesis. If you look at this, if you have prostaglandin that's created by this COX, prostaglandin play very critical role in immune function. So propofol can inhibit this, so it's better for him. The last thing that propofol also do is the reduction of the hypoxemia inducible factor 1A. That's a very important factor. HIF 1A is actually used therapeutically because it's the body regulate the body response to hypoxemia. And what it does is enhance the neoformation of vessels. Like this, because it's a hypoxemic area, by increase the vessels, you increase the blood flow. The quantity of vessels that go there, you increase the blood flow to that area, and that's what fight hypoxemia. It's appeared to be that the same time that HIF-1 will promote also cancer, because the cancer growth lie on all this blood substrate to proliferate. The proliferation of it will be halted if you don't use this ability to create more vessels. So it looks to be that if you inhibit this HIF substance, you potentially prevent the growth of metastasis. From the other hand, inhaled anesthetic are found to be, they create proliferation of the glioma cells, and they enhance the HIF factor. Isoflurane is the same thing, HIF factor. So both this volatile anesthetic actually increase your incidence in cancer surgery to have metastasis. In fact, we are just starting a study looking at 2,000 patients, one group inhaled anesthetic, one to propofol, and to see in 2 years in thoracic, GU, and hepatobiliary to see if there's a make a difference in 2 years incidence of hypoxemia. One interesting study that came out, that I just want to show you, came out from England, and just last year, and they analyzed a lot of patients. I'm not going to show you the whole data, but they end up with 3,000 patients in each group of inhaled anesthetic versus TIVA. And if you look here, this is the survival, total survival. This is the propofol versus the inhaled anesthetic, much higher survival. And then they look at the ASA status ASA 1 and 4 in both. In ASA 1 propofol, ASA 4 propofol, much better in both propofol versus TIVA. And if you look also with metastasis and without metastasis, those without metastasis, and this is, of course, those with metastasis die more, without metastasis, with metastasis, in both propofol was better in survival than inhaled anesthetic. So now we change. We say that propofol is right and inhaled anesthetic are wrong. So it is the conclusion of that, however, of this editorial that came this month, that actually to date, we cannot really conclude yet